Hey, Jerry Pal listeners. Wait, Alex, Eric, do you even know who's listening out there?
No.
I know Alex is. He's got headphones on.
Well, don't you think it's time we found out?
How would we do that?
Listeners, do us a favor. Log into jerrypal.org and complete our 1-minute survey. We want to know who you are and how we can do better.
Welcome to the Jerry Pal podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, we have some people, very special people in our studio audience.
Very special people in our studio audience.
Studio audience? Studio?
In our studio.
It's not like it's almost our 100th podcast. I should have this intro.
We should have the intro down by now.
Down pat.
We have Kate Possin, who is a neuropsychologist at the UCSF Memory and Aging Center. Welcome to the Jerry Pal podcast, Kate.
Very happy to be here.
And we have Sarah Dulaney, who's a clinical nurse specialist also at the Memory and Aging Center. Welcome to the Jerry Pal podcast.
Thanks.
Sarah.
I'm a big fan.
All right.
I am super psyched about this podcast because I think it's amazing. Like, it really is. The more I read about it, and I went through like all your online stuff, the more excited I became about this. So we're going to be talking about the care ecosystem. It's a JAMA paper that just came out in Internal Medicine. I guess care ecosystem is in the JAMA paper, but they just published in JAMA Internal Medicine about this project. And we'll talk more about that. But before we do you have a song request for Alex?
Yes, we do. It's Forever Young by Bob Dylan.
Oh, when you said Forever Young, I thought it was Alphaville. Anybody remember the German synth pop band Alphaville? Remember?
No.
Forever young, who wants to live?
Oh, I do remember that.
Yes. Let's do that one.
I didn't prepare that one.
That was the one we should have John Newman do when he did it.
Oh, right.
Living Forever
we did,
through.
Right. Who Wants to Live Forever by Queen.
Yeah. All right. I don't know this one.
Here we go. Bob Dylan, classic.
Do I get to say why I picked this one?
Yeah, why'd you pick it?
Why'd you pick it?
Because my mom sang it to me when I was a kid, and
Really?
also because the director of the Mac, Bruce Miller, is a big fan of Bob Dylan. So 2 reasons.
Does he like Alphaville though?
Probably not.
Probably. Alphaville, if you're listening, we are sorry.
May God bless and keep you always. May your wishes all come true. May you always do for others and let others do for you. May you build a ladder to the stars and climb on every rung. May you stay forever young. May you stay forever young.
Nice.
Great.
Who wants to live forever?
We got disco fever.
Before we jump into the JAMA Internal Medicine paper and care ecosystem, I'd just like maybe take a step back. How did you get interested in this, in particular dementia and helping caregivers? Either of you can start.
Wow. I think we've both been at it for such a long time. I can say why I got so excited about the idea of the care ecosystem. I was a neuropsychologist studying brain behavior relationships and taking care of patients at the Memory and Aging Center, and noticing we were providing quite good care at our tertiary center, but that most people with dementia and their families were not receiving this type of care. Most never even see a dementia specialist. And so I felt compelled, along with my colleagues, to design a model of care that could reach patients and families wherever they live. And so this idea really took us on this journey to the care ecosystem and the continued journey to try to transform dementia care.
Mm-hmm. And how about for you, Sarah?
Well, if I really step back, I was a modern dancer, and I got into this because I had to have a side job to support myself, and I worked with people with developmental disabilities. And one of the people I worked with, her mom, she was in her 60s, and her mom was 80, single mom, raised this woman with a developmental disability. Her husband left and everything. So I ended up being an AmeriCorps volunteer and working with people with developmental disabilities, and went from that to dementia. So I was a live-in caregiver for 2 years as an AmeriCorps volunteer, and just kind of, I love people with different behavior. It's super interesting, and working with caregivers, I think they're just like the heroes of today. So
you started out as a modern dancer and then became a geriatric clinical nurse specialist as a side job, and now that's your job. It's a lot of fascinating pathways
prerequisites
people take.
From dance to this.
And I think that's the fascinating thing, like especially in dementia care, but really in care for most older adults with multimorbidity, frailty, that we rely on caregivers so much from a medical system, but we do almost nothing for them. It's impossible to find the name of a caregiver in most EHRs. Like, it's just not there.
Thank you.
What the? But it's we can do like TAVRs and these really expensive procedures, but God forbid we do anything for the person who's actually keeping this individual at home, and let alone naming them in an EHR.
And if they didn't exist, like, good luck with your patient, especially if they have cognitive impairment. I mean, there isn't, aside from putting someone in a nursing home, which is really expensive and inappropriate for people through most of the course of their life with dementia, there isn't a program or system that can do everything that a caregiver does.
Yeah. And very rare programs out there to help caregivers, aside from the one that you guys just made. Care ecosystem. Can you give us a little bit of background? Like, what is care ecosystem?
Absolutely. So, all right. So the care ecosystem does indeed think about the patient and the caregiver together in providing the care. And that is really at its core. And we pair that team with our care team navigator. So the care team navigator is an unlicensed dementia specialist. We train them. So it could be somebody who's fresh out of college, maybe wants to go on to be a nurse or a doctor in the future, and they go through our training program.
So they don't need any formal medical training prior to your training.
That's right. And the training program usually takes about a month with us, and then they're ready to go. The key ingredients in a navigator is not what, medical degree they have. It's that they have a lot of empathy, that they communicate well on the phone, that they're excited to help our people with dementia and their families navigate this complex disease. Those are the key ingredients. So we pair a care team navigator with the family, and they develop a relationship together. They're over the phone. It's all over the phone, internet as well. And the care team navigator,
and video conferencing internet, or
if they want, it's up to the caregiver. If they want video conferencing, we'll do it with video conferencing.
I've been surprised that not as many people have wanted video conferencing, but the people who do are pretty reliable. But sometimes people, we have to talk to them when they're on their lunch break at work or driving home from work on the phone. And so video is not really possible.
So no in-person visits. This is all done.
There are some in-person visits. So some of the people enrolled in our study are also seen at the Memory and Aging Center clinic. Yeah. And, caregivers love the opportunity to meet people. So if the person is still coming into clinic, they'll ask, if the navigator can come to the appointment with them. And they love that. But it's not always possible. And, we serve people across the state of California, our partners at UNMC in Omaha, Nebraska serve Iowa and Nebraska. And so phone is for the majority.
Wow.
And the first thing that people think when they hear it's a phone-based program is, wow, great, that probably saves a lot of money. And maybe that is true. We think it is true. But we think it's actually better care for these families. They can get the help when they need it. They don't have to make a doctor's appointment. They don't have to take their loved one with dementia into the car and drive to that doctor's appointment. No, they get help when they have an urgent situation, when the patient's acting agitated and they don't know how to handle it. And furthermore, we can reach patients and families wherever they live. There are many parts of this country where there are no dementia specialists. And so that lifeline to us is the only access that they have.
I loved your map on the JAMA Internal Medicine article. You can actually see where these individuals are. And it's not just in like dense urban areas like San Francisco. Like, it's in Central Valley in California. It's in like most people think of Northern California as San Francisco, but like we have hundreds of miles north of us that's really rural. And there's little dots all over there.
Yeah.
It's interesting. So is it? Do you give them these persons with dementia, their caregivers, instruction that if you have an emergency, call us first?
No, we have a guide because we're not providing the medical care for these people.
Right.
And so we come up with a plan for them for, if we actually developed a little guide. So if they're having something like a rash or an upset stomach or even a sudden change of behavior, they can call us for that. But if we teach them about delirium really early on, that your really sudden changes in function or behavior is something that often needs a medical evaluation. We also give them the 24/7 helpline from the Alzheimer's Association because that's an important resource. It really can help people de-escalate a situation, if any 24/7. So we rely on that for people after hours because we're not a 24/7 on-call service. And, we give them guidance around, when you actually do need to take someone to the emergency room if they're having difficulty breathing or if that's part of their goals of care.
This is fascinating. So we have had a couple of podcasts now about the navigators, sort of lay health navigators, community navigators, et cetera. And one of the key pieces is always what kind of training do they receive? So I hear that they're trained about delirium and maybe rashes. Can you tell us what else you cover in that 1 month
Well, they're
training?
not necessarily trained about rashes.
Right.
They just know they can't handle rashes.
Okay.
It's mostly about learning their scope and
right. What's within the bounds and when they need to refer to somebody else.
Right.
Yeah.
Right. So they have a lot of standardized materials. So what I mentioned, this guidance, it's written down on I think it's called a safety plan. And it has their doctor's information and who to call when. And it says when to call their CTN. And it's mostly around when they need someone to talk to or when, they're not sure if this is normal or not, with dementia.
CTN being Care Team Navigator.
Right.
And so to tell us what kind of, what else was in the training in this 1 month for these navigators?
Well, we have Aging 101 and ethics that's taught by Anna Chodos, a geriatrician from UCSF. We have medication, that's medication issues in aging and with dementia, which is taught by pharmacists. We had Kirby Lee, and then now we're working with Shalini Lynch. And I do, dementia basics, and we talk a lot about behaviors. Jennifer Merrill's, another clinical nurse specialist, investigator on our team, talks about behaviors and also caregivers, supporting caregiver challenges. We have a social worker on the team that talks about benefits, Medicare, Medicaid, other community benefits, and an attorney, Sarah Hooper from the UC Hastings, and Winston Chong, a neuroethicist, neurologist. They've really put a lot of thought into advanced care planning, both medical, legal, and financial, and how they get training on capacity in dementia, not how to determine capacity, but just being aware that it's really important to get advanced care planning conversations in while someone has capacity, and also learning about end of life and the kinds of decisions people have to make, and supporting them in making these decisions, trying to honor the person's values.
And that's a pretty amazing all-star cast there. And when I first read this article, part of me felt like, okay, I've seen this before. This is stuff that's going to be published. Nobody's going to really have access to it except for this local institution that does this. But then I started reading through your stuff and clicking through all the links. You can actually go to your box folder and download all this stuff, go to your website and actually do the training. I was so impressed how available this information is. I was just downloading stuff left and right today just to see what's there.
And the whole training program too is all available now for free through Coursera. So if a health system wants to adopt this program, through
Canvas. I do this amazing thing.
Yes, and right. So a health system leader can go and access all of those video trainings for new care team navigators and get them up to speed.
That is so, the thing that made me, I'm really cynical now after the MoCA started charging for use. So, and I'm just so impressed by kind of making this very open access so anybody can actually use these tools. It's really refreshing. So Thank you.
I think the other thing about that is, we've done things a certain way here that works for our team at UCSF, and our implementation sites are all kind of adapting for their setting. And I think we're learning a lot from ways that they're adapting it. So I think people don't have to try to do it exactly the way that we've done it. I mean, we've had to do it a certain way because of being a randomized controlled trial, and also not being linked necessarily. People aren't all UCSF patients, so we're serving people outside of our health system, whereas our implementation sites are serving people within a health system. So there's some adaptation for that.
And we'll have links to all of your website and some of this material on our GeriPal post that's going to be accompanying this podcast. I was also wondering, are there key protocols that these CTNs care team navigators that they you guys made sure that they did throughout the course of their time with their caregiver?
Well, not everybody is going to get through all of them. We do train them to, that's the goal, is to go through all of the protocols, which include advanced care planning and medication review and reconciliation, checking on medication changes, behavior management, safety, screen, and working on attending to caregiver well-being specifically, referrals to community and education resources. That's sort of an ongoing thing. So some of the protocols, I think they're probably following some of it on every call, and others, it just depends on whether the caregiver can get there. Some caregivers don't necessarily want to be caregivers, and they are really resistant to anything, around continuing that role, even though they might feel kind of stuck in it. Yeah. So, it depends on how, it's really individualized. Yeah. So we have the protocols as a guide.
And who else is involved? So you have this care team navigator, but there were other people, that were involved in the care ecosystem,
I think
right?
the team-based aspect is really important because I think, like you said, you're getting sarcastic about the MOCA. I think in dementia, there's this tendency to become fatalistic of I can't think of anything else that's going to work. And that's what's important about having a team. Yeah. And, the evidence around medication or any of these strategies is not so strong that you can just say black or white, this is what you should do. So it's, helpful to have a team to discuss this is what's going on and what do you think? And, the caregiver is going to have their own opinion. So it's really a collaborative process. And I think that team aspect, we meet every week and we discuss challenging cases.
And who's on that team?
So all the care team navigators, and then in our in-person weekly meeting, we have the 2 clinical nurse specialists and then our social worker. And we have a monthly call with our pharmacist because we found when the pharmacist was in on the in-person meetings, the medication aspect really dominated the discussion. And so we save the medication call, and then they're available to consult electronically, outside of that monthly call. But so our weekly team meeting is the social workers, nurses, and care team navigators. It's a lot of fun.
Yeah. So this is, we have some understanding of what the care ecosystem intervention involved. Now you studied it for this manuscript here, and it looks like you had 3 sites, as you mentioned. You had basically 2 main sort of hubs, right. But you recruited patients from California, from Nebraska, and from Iowa, and you had a single blind randomized trial. You had sort of 2-to-1 patients with dementia and caregiver dyads, and about 500, and then about 250 dyads who received usual care. So about 500 in the intervention, about 250 in the control group.
Is it hard to recruit caregivers?
Well, we found the easiest. We tried lots of methods to recruit because we had very ambitious recruitment targets, as you can see. So we tried a number of different methods, and the method that yielded by far the most dyads is by working directly with trusted providers. So going to primary care physicians and using their EMR to run lists of patients with dementia, And then, writing a letter to those families signed by the physician, inviting them to participate, and then we'd follow up via phone. This got most of our patients. But what we found is we were getting a bias in our sample towards people who had, more education, more resources using this method. So we then did a lot more community outreach to try to bring in people from more underserved communities, giving talks or connecting with community organizations. It was a lot more work for each enrollment, but it helped us bring in more underserved people, including monolingual Spanish-speaking and Cantonese-speaking cohorts.
And is this designed for all stages of dementia, like mild, moderate, severe, like when we're thinking about who this is appropriate for?
Yeah, and we follow people. I mean, it's been a real pleasure and joy to follow these people, from the study. Some of them we've followed for, 4, almost 5 years. So it's really, you get to follow them when they're maybe not even seeing their provider anymore. They're on hospice, they graduate from hospice, they're on hospice again.
Heard about that. Yeah.
So really throughout the life course.
Throughout the course. Yeah.
And we think that's so important. We really designed this model of care to work ideally from diagnosis all the way till the end stages of the disease. And the care needs to be tailored throughout that. There's different needs that emerge throughout the different stages of dementia. And there's also times when things might be going pretty smoothly and the family doesn't need a lot of help from us. But then some sort of new crisis emerges, and it really helps them that they have that relationship in place.
And what was the main thing that you're hoping to see when you're doing this study? Like, what were you hoping to see in the results?
I mean, I was thinking more about just helping people.
Right. Well, we thought a lot about the outcomes. This was the first randomized controlled trial that I've ever run. And we, first and foremost, wanted to improve the quality of the life for the family with dementia. This intervention is not designed to slow down dementia. It's designed to improve the experience for the people living with the disease.
Did it?
And yes, we were so thrilled that, yes. So when you run a clinical trial, you have to pre-specify your primary outcome, and that has to be significant for it to be considered a positive trial. And so we were very fortunate that our primary outcome, quality of life for the person with dementia, was significantly improved in the treatment group relative to the control.
Mm-hmm. And that's as rated by the caregiver on a
Correct.
rather large scale.
Correct.
That covers a number of domains.
Yes.
Yeah. Is there any way of sort of, it's hard to quantify quality of life. Like, quality of life was improved marginally for a lot of folks, or was it improved in a big way for a few folks? Or is there some way of sort of, because I see a beta coefficient here, but I don't exactly know how to interpret that.
Everybody wants the answer to this question. That's a lot harder to answer than you might think at first blush. But, on average, the treatment improved quality of life by 0.5 point for each patient. What does that mean? Well, if you move 1 point, that means that a key component of quality of life moved from poor to fair or from good to excellent. So that seems clinically meaningful to me.
Great. And you had other outcomes that you looked at. What were those outcomes, and what did you find?
We also looked at utilization by the patient. So in other words, we looked at ambulance use, emergency department use, and hospital use. And what we found there, and this was all, again, caregiver report. We will be looking at claims data from Medicare claims data as that becomes available. So this is all caregiver report. And we ask every 6 months about the utilization. And what we found was that the program reduced the emergency room visits of the patient. So, this was really exciting. I think it suggests what we tried to do may have worked, reduce this crisis-oriented approach to care that we see so often in dementia.
Do you remember by how much did it reduce it?
So for every 5 patients who were enrolled in the treatment, we reduced an emergency room visit for 1. So the number needed to treat was 5.
Wow.
Which is amazing when you think about the number needed to treat for common interventions that we use every day in primary care, like statins for secondary prevention. I just looked this up, and the number was like 300.
Yeah.
So high. This 1 in 5 to prevent an emergency department admission.
I think Aricept doesn't do that. Yeah, everybody's on it.
So there was a line in your results section about cost outcomes. And so it wasn't a major feature of the paper, but it stuck out as, potentially cost savings. Is that right? When you added up the costs of the services that you provided and the acute care visits that were avoided, it ended up being something, was it around $600 per dyad?
Yes, that's right. And we saw all of the cost savings in the latter 6 months. So this was a 12-month trial. And it takes a while to get the care plan in place and work with the caregiver, address their needs first before interventions are implemented for the patient. So all of these cost savings, about $600 per person with dementia, were realized in the latter 6 months. We're now continuing this trial. So we're continuing it for 5 years. And so we're hopeful that we'll see those cost savings be maintained or grow even further.
That is fascinating.
So improved quality of life, less utilization as far as ED, and it's cost savings.
Yeah, and how about the caregivers? Did you look at study the caregivers at all? Any outcomes with them?
Wasn't that the quality of life?
No, the
That
quality
was
of
for the
life
patient.
for
that was
the
for the
person
patient.
with dementia as rated by the caregiver.
I get it now.
Yeah.
Quality of life for
Right.
the caregiver?
So we measured the well-being of the caregiver in 3 ways, and all of them showed significant effects. So we improved self-efficacy of the caregiver by 6 months. So they're feeling that they can take care of their loved one, that they're prepared for the future challenges. We decreased depression in the caregiver. And this is really important. We also had another publication recently in JAMA Neurology that showed that caregiver depression is a big predictor of emergency room visits in the patient. So this may be one of the mechanisms by which we are reducing emergency room visits. And we also reduced feelings of caregiver burden.
So I think this is really important when you mentioned that there's no caregiver's name in the electronic medical record, because it's not even just that their name or phone number might not be there, but we're not considering, how does this caregiver feel about managing this person's care? I mean, their caregiver's mental health, and another study has been shown to affect the patient's mortality.
Yeah.
So I think we're really missing a big piece of what affects the patient's overall health.
So this is tremendously exciting results. And people are going to want to unpack this and see, well, you did this multi-component intervention. What worked?
What's the one piece we can take?
Right. Well, but from your angle, as it being embedded in this and doing this work for so long, like, are there any stories that you could carefully anonymize, for example, for public consumption about, so-and-so, we reached out to this caregiver, they're having this issue, and we address that. And we think that that's the sort of impact that our study had.
Well, the thing that I think is the biggest secret of the caregiver system is people think, oh, it's over the phone. Like, what do you actually know? Like, you're not in the house. You're not really seeing what their life is like. You're missing like half the picture. And I think the fact that, for some of the really people who need a lot more help, we also work with some caregivers who may have some cognitive impairment themselves. They're also in their 80s and they might forget the name of the care team navigator. And if they don't call them every week, they might forget, to answer the phone or something. So who else is seeing that person? Like they're forgetting their doctor's appointments, or the doctors. We've had a lot of people who the primary care provider has changed. Primary care providers in some areas don't accept Medicare patients, and so the continuity of care that the care team navigator provides, and APS, you refer to APS, they close the case in a month. They may not open the case. They may not see the situation as, dire enough depending on their resources. And so, we're able to keep at plugging away and making sure that someone is getting the help that they need. And again, with the team of being able to think of like, what else can we do? What other resource might be there? Yeah, I mean, I think the people for me that really make it, we had someone who had a lot of ED visits. The caregiver was just super overwhelmed, and his wife is so attached to him that she really, they had her in a nursing home temporarily, and they couldn't keep, she was constantly asking about her husband, where is he? And so we were able to help them, figuring out how to qualify for Medicaid, for example. If your income is sort of borderline, like that takes a lot of skill and advocacy and just, having paperwork. So helping people access like in-home supportive services. So at least, she could be in the home with a little bit more help and support for the caregiver, so they're addressing their needs and advocating with the primary care provider that, sometimes we need medications just so that the caregiver doesn't lose it.
And I love that aspect too, because it really did feel comprehensive. It wasn't just about like medications and polypharmacy and advanced directives, but also thinking about those things that caregivers, like when you're a caregiver of somebody with dementia or when you're a loved one, it's like, oh my gosh, I never thought about like what happens to the finances? Who's going to manage that? How do I even manage like his finances? I don't have access to his bank account. The banks don't. Like thinking holistically what matters to people with dementia. And when I was looking through the protocols, a lot of those things were in there.
There are so many little things you wouldn't even imagine. Like we had one lady who she was getting older and shrinking, and she had this hairdresser that she got her hair done. Then she no longer fit in the seat to get her hair cut. And that was like she refused bathing. So it's like actually really important that she goes to the hairdresser to get her hair. That's when she gets her hair washed. And so like calling around to try to find places where, they can have a booster seat or something on the...
That's great. These practical, creative solutions, right? And you don't need a physician to help. Right.
And it's actually a lot of work calling around to make all these calls. So you don't really need a nurse or a social worker doing that either.
Right. Yeah. Going back to kind of the study and the care ecosystem, how do you define who is a caregiver? I can imagine for a lot of these patients, they have formal and informal caregivers. They have a family member in Connecticut who's providing a lot of caregiving, but from a distance, and a formal caregiver here. How did you guys think about the word caregiver?
For the trial, we wanted to identify one caregiver who was going to stay with us for the whole trial. It was really important for the measurement to have the same caregiver answering the questions at each survey time point. But in reality, patients often have a team of caregivers, or at least we hope they do. In fact, if they don't, we often try to help them get a team of caregivers. Right? Yeah. We just looked for someone who identified as a primary caregiver, and they didn't have to live with the patient. Some of them lived in other states. For them, nearly all were a family member. Most were spouses, followed by daughters.
Mm-hmm. And we were talking about this a little bit beforehand. We were kind of joking, but sad but true, that with results like this, if this were a drug, some pharmaceutical company would have picked it up and making, billions of dollars off of it. But it's not a drug. So I guess the next question is, you have impressive results. There have been other studies of dementia care. You mentioned some in your discussion, based out of UCLA, based out of other places. That have also had encouraging findings. Yours is distinct from those, but there, in some, there are a number of potential interventions that could be done that are non-pharmacological and have promising results for people with dementia and their caregivers. What can we do to change the system, or what hope is there for these interventions being implemented in this country?
This gap between practice and research is one of the biggest challenges. And it's one that we have thought about from designing this intervention. Everything that we did here at the care ecosystem was with an eye towards scale in terms of how the intervention was designed, that it can work from hubs, extending the reach of specialists, for example, making it phone-based. We were always thinking about scale. We were really influenced by people like Laura Gitlin, who write about this science practice gap. So what can we do now? Well, one thing we're doing is trying to make the process for setting up the care ecosystem as easy as possible for health systems. I mean, it's never easy, but as easy as possible. And so that's why our trainings are online, the toolkit. If you go to our website, it's a one-stop shop for everything care ecosystem. So we want to give them the tools. We also published a paper on the costs of setting it up so health systems can plan for those costs. The startup costs, there's always startup costs in setting up a new program. And unfortunately, Medicare doesn't usually pay those costs. And so we find health systems need to get some philanthropy or a grant to get a program like this off the ground. But then we provide a lot of guidance on, potential billing mechanisms or other ways to sustain the program.
I loved your toolkit. like reading it. Like, how do I talk to my stakeholders about like thinking about this? What kind of questions would they have? Like, it's a great toolkit for starting this up. And I think that's what often is missing in most of these interventions. It's, oh, look at this great thing that we did. And then it stops at the publication and nothing after that. You don't see it in many other places. And this is just, it's there. It's built into the study too. Like, it was impressive.
For us, the metric of success is not that we publish this paper. The metric of success will be that health systems are delivering this care to families.
And getting on the Jerry Pal podcast.
This is, yes, right.
That's their ambition.
We can go home now.
Right. Yeah, right.
We're done. You can go back to dancing, Sarah.
That's right. And are there health systems who are interested or who are starting to participate?
Yeah, so I think because we put these materials online, and even before this paper was published, health systems were reaching out to us, and we were always so excited to take those phone calls and talk to them about their as they were considering setting up this type of program. And 3 different health systems decided to go forward with it around the same time, around June of 2018. It was pretty cool that they all at the same time. So Oxner in Louisiana, Health Partners in Minnesota, and University of Colorado at Denver as well. And so we've been working together as a team. We have monthly calls, all 4 of our groups together, to talk about the challenges that we're all facing and how they're adapting the program for their health system, how they're approaching sustainability so that we can learn from each other. So we're actually studying the process of implementation and offering our help as much as we can to these health systems to maximize the likelihood of success. We hope now that this paper's out, we'll get some more phone calls from other health systems.
Right?
We can't wait for those phone calls. So please call us.
So we'll have the link to your website. Contact information is on the website too, if they're interested in learning more about care ecosystem and starting it up in their healthcare system.
Yes. Please send us an email.
Help us build a care ecosystem as a national model of dementia care.
Yes, it should be. It should be our care ecosystem. Oh, last question from me. Why care ecosystem? Why that term? What is ecosystem?
Someone on the team before I came along came up with it, but I think it's brilliant.
I mean, I was kidding with Eric beforehand. He was because they plant trees as part of that's not it.
Yeah, I think it refers to the multidisciplinary team nature that's needed to take care of dementia, that we're involving the family, that we're involving the navigator, the existing providers, and our multidisciplinary dementia specialist team, that we all need to work together and address whatever the needs are to help the patient.
And I love that you included community providers, like Alzheimer's Association, amazing resource for individuals out there. It's so underutilized.
Yes.
Yeah. And I think this really illustrates the ecosystem nature of dementia care, and that if you provide robust support for caregivers, which is to me one of the major components of this intervention and why it was successful, then you will impact not only the caregiver, but also importantly, the person with dementia. And so that in an ecosystem, any given piece, if it's not supported, it affects the whole system. And I think that's absolutely true here.
Great. With that, I think I want to send you a big thank you for joining us today on this podcast. But maybe before we say goodbye, we can have a little bit more of
Bob Dylan.
A little bit more Bob Dylan. May your hands always be busy. May your feet always be swift. May you have a strong foundation. May the winds of change shift. May your heart always be joyful. May your song always be sung. May you stay forever young. May you stay forever young.
If you want to live forever.
Still stuck on Queen.
And ever, forever young. Who wants to be forever
I'm
young?
going to have that song in my head all day.
Oh, no, that's the other one.
That's Alphaville.
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 Yeah.
Yeah, for all those folks who grew up in the 80s, you're welcome. And with that, I want to say big thank you to our listeners for joining us today, and both of you for joining us and giving us this great tour of care ecosystem.
Thank you, Jerry Pal.
Yay! Thanks, everyone.
Bye.